Good evening, everyone. Am I audible?
Good evening, ma'am. Yes, ma'am, you are audible. You can share your PPT, then we'll be starting.
Sure. So today we'll be doing the part 2 of dermatology for MRCP part 1 and 2. So I've divided topics into 4 classes. So today also we will be going into major topics that are very much important for your exam. Okay. So let's start from pompholyx. So pompholyx is nothing but a type of eczema, and it affects both the hand and the feet. If it affects only the hand, then it's called chiropompholyx, and if it affects only the feet, it's called pedopompholyx. The other term that is used for pompholyx is nothing but dyshydrotic eczema. So always remember, pompholyx is also called dyshydrotic eczema. In your exam, you can have questions where they mention it as either pompholyx or dyshydrotic eczema. All right. So what are the features of pompholyx? So it can have small blisters on both the palms and the soles, and they're usually itchy and pruritic. Sometimes the patients might have burning sensation as well. And once the blisters rupture, the skin may become dry and it might have a cracked and dehydrated appearance. Well, so how do we treat pompholyx? Mainly by cold compresses, emollients and moisturizer, and also steroids. Okay. So the next one is nickel dermatitis. So nickel dermatitis is a type of allergic contact dermatitis. Okay. So it is an example of type 4 hypersensitivity reaction and mostly caused by jewelry like chain, watches that contain the metal nickel. And how do we diagnose it? It is mainly by skin patch test. So they do not go much into this nickel dermatitis in your exams. The main question that they might ask you is what kind of a reaction it is. So it's the type 4 hypersensitivity reaction. And how do you diagnose it? You mainly diagnose it by a skin patch test. All right. So just make notes of all these highlighted points that I've put here and there so that it will be easy for you to revise at the end. Yeah. Next topic is erythema of ignis. So it is a skin disorder that is caused by exposure to infrared radiation. And how does it classically present? It presents in front of the lid due to the patient sitting too close to a fire or a heater, which radiates infrared radiation. And it may also arise as a response to chronic hot water bottle use. So patients might be using, hot packs that very frequently that it might emit infrared radiation and cause a skin disorder called erythema of ignis. And coming on to the characteristic features of this, it is characterized by reticulated erythematous patches with hyperpigmentation and telangiectasia. Okay. So a typical history in your exam will be like there's an elderly woman who always sits next to a heater or an open fire. And also patients with hypothyroidism who feel very cold, usually they sit next to a heater or a fire. So the history might be an elderly woman with hypothyroidism who's feeling extremely cold and always uses a heater or a fire. So, and if the cause is not treated, these patients might develop squamous cell skin cancer. So what you have to remember in this topic is it's a skin disorder caused by exposure to infrared radiation, how the history goes, and risk factor of developing squamous cell carcinoma. Okay, so this is an image which is depicting how an erythema of ignis looks. They can give you an image and ask what this condition is, and they can give you a history as well. So image is also important when it comes to part 2 mainly. Next topic is erythema multiforme. This is a mucocutaneous inflammatory condition characterized mainly by target lesions or a bullseye lesion. So I have put the images here. If you can see the pictures, you can see a target lesion or something that resembles a bullseye. Okay. So they erupt usually 24 to 48 hours and last for almost 1 to 2 weeks. And this is also a type 4 hypersensitivity reaction. And it presents in a symmetrical distribution. Correct? Mostly the lesions are over the dorsal surfaces of the extremities with minimal mucous membrane involvement. Most commonly, it affects only the skin. That is, it's more of cutaneous lesion. All right. So here the characteristic thing will be bullseye lesion and target lesions. So whenever you see that in your question or whenever you see that in any history, you have to remember this is a form of type 4 hypersensitivity reaction and it is erythema multiforme. And there are various causes to this. So the most common is herpes simplex virus infection and ORF virus as well. It can be idiopathic. And which are the bacteria that can cause erythema multiforme? It is mostly mycoplasma and streptococcus. So that also you will have to remember. HSV, mycoplasma, and streptococcus. So coming on to the drugs that can cause erythema multiforme, most common penicillins. Next will be sulfonamides, sulfonylureas, barbiturates, carbamazepine, and allopurinol. Okay. NSAIDs, OCPs, and nevirapine as well can cause erythema multiforme. And so certain connective tissue disorders also can lead to erythema multiforme, and the most commonly seen ones are SLE and IBD. And sarcoidosis is also a very common cause of erythema multiforme, and the last one being malignancy. So how do we classify these lesions? They can be classified as erythema multiforme minor or erythema multiforme major. Okay, so minor is when the body surface is less than 10%. Okay, it typically occurs as target lesions or raised erythematous papules with acral distribution without the involvement of any mucosal sites. Okay, so in minor, there is only cutaneous involvement and less than 10% body surface area and no mucosal involvement. Whereas in erythema multiforme major, typically has target lesions with raised edematous papules with acral distribution, plus involvement of one or more mucosal sites and involving more than 10%. I am very sorry here I have mentioned less than 10% body surface area, but it is more than 10% body surface area in major. Okay, so major will have mucosal involvement as well as body surface areas more than 10%. So as I mentioned earlier, the is a target lesion or a bullseye lesion. Initially seen on the back of the hands or feet, spreading to the torso. So it starts from the limbs and spreads upwards. Upper limbs are more commonly affected than lower limbs. Pruritus or itching is occasionally seen and very, very mild in these conditions. And if the symptoms are very severe and involves blistering and mucosal involvement, then it is known as Stevens-Johnson syndrome, which is another important condition for your exams. We'll discuss that next. So what is the treatment for erythema multiforme? Usually it involves supportive care and treatment of the underlying condition or infection, whatever is involved. Prognosis, it is usually if the disease is mild, and in cases of erythema multiforme minor, it is self-limiting, and the lesions usually heal within 2 to 3 weeks without any scarring. Okay. What are the other related dermatological conditions associated with erythema multiforme? Can be Stevens-Johnson syndrome. It can be toxic epidermal necrolysis, or it can be Stevens-Johnson syndrome, toxic epidermal necrolysis, overlap syndrome. All right. So firstly, we'll look at Stevens-Johnson syndrome. Here, they are severe macular lesions that coalesce, that is, they join together, resulting in epidermal blistering, necrosis, and sloughing. So here, you do not see typical target lesions. In Stevens-Johnson syndrome, what happens is all the lesions coalesce and they join and combine together to form a very large lesion, which where there's a blister, and also there is necrosis and sloughing of the skin. It involves less than 10% of the body surface area and may present, sometimes it can also present with only mucosal involvement. Okay. Next is toxic epidermal necrolysis. Here also the lesions are severe macular lesions that again coalesce and combine together with resulting in blistering, necrosis, and sloughing. And here the difference is that more than 30% of the body's total body surface area is involved. When there is overlap between Stevens-Johnson and toxic epidermal necrolysis, the lesions can vary anywhere between 10 to 30%. Okay. So how do we differentiate erythema multiforme from a Stevens-Johnson syndrome? So in the erythema multiforme, the lesions usually begin on the extremities. In Stevens-Johnson, they usually begin on the face or the trunk. And in erythema multiforme, it is commonly related to infectious diseases, whereas in Stevens-Johnson, more than 50% of the conditions are due to adverse reactions because of medications. And you can see typical target lesions and bullseye lesions in erythema multiforme, which are not seen in Stevens-Johnson syndrome. Coming on to the histology, High density of cell infiltrate, which are rich in T lymphocytes, is seen in erythema multiforme, whereas poor infiltrate of macrophages and dendrocytes are seen in, with strong tumor necrosis factor are seen in Stevens-Johnson syndrome. Okay, so these are the major differences. Just keep in mind when it comes to your exam, the percentage of body surface area, whether there will be mucosal involvement or not, or how the typical lesions present, whether there will be target lesions or whether there will be coalescing lesions. All this you will have to keep in mind, not just for your exam point of view. Even when you get a patient, you have a patient in your hospital, post drug reaction patient develops a severe rash, where there's blistering initially, and then there is necrosis, sloughing of the skin. The skin is again gets it. These lesions can also get infected, leading to secondary bacterial infections. So it is very important to identify them and then treat them earlier, so that it doesn't progress to very severe infection. They can also lead to death because of severe dehydration and sepsis. So Stevens-Johnson syndrome, as mentioned earlier, is a severe form of erythema multiforme, which is associated with mucosal involvement and systemic symptoms. It is now known as erythema multiforme major, where there is more than 10% body surface area. Okay. Major features include rash, which is typically maculopapular with target lesions coalescing to form large lesion. Either vesicles or bulla or blisters may be seen. Mucosal involvement will be present, and this condition is associated with systemic symptoms like fever and arthralgia. So again, coming on to the causes, they are similar to erythema multiforme, but more commonly mainly because of medications. So next is toxic epidermal necrolysis. Toxic epidermal necrolysis is severe mucocutaneous exfoliative disease with an uncertain pathogenesis and with a very high mortality rate, mainly because the body surface area involved here is more than 30%. Stevens-Johnson is only 10%, but here it is more than 30%, so it is life-threatening skin condition. In this condition, the skin develops a scalded appearance over an extensive area. Some authors consider toxic epidermal necrosis to be severe end spectrum of the skin disorders, which includes erythema multiforme and Stevens-Johnson. It is also considered as a dermatological emergency. Okay, so most commonly it is idiopathic, where you will not be able to identify or find out any underlying cause. Other common causes include viral infections, leukemia, lymphoma, and drugs. Okay, mainly sulfonamides and anticonvulsants. So, what are the main features that you see? Here, again, patients can have systemic symptoms, for example, pyrexia, arthralgia, tachycardia. They can have tachypnea as well. And because of severe mucosal ulceration, they can also lead to further secondary infections. And one more thing that is seen here is positive Nikolsky sign. Here, the sign is nothing but the epidermis separates with mild lateral pressure. Okay, so Nikolsky sign is nothing but when you apply lateral pressure, you can see that the epidermis over the skin separates. All right, you have to remember that 10 has, that is toxic epidermal necrolysis, has Nikolsky sign. So most common drugs that can cause death are phenytoin, sulfonamides, allopurinol, penicillin, carbamazepine, and NSAIDs. Always remember, NSAIDs can lead to various skin reactions, leading like starting from erythema nodosum to erythema multiforme to Stevens-Johnson's to toxic epidermal necrolysis. All right. So how do you treat the patient with toxic epidermal necrolysis? You will have to stop or discontinue the offending agent or the precipitating factor of the skin lesion. Supportive care is most important, and all patients with toxic epidermal necrolysis need ICU admission. Intensive care admission is essential. Whenever you identify that this patient is going into toxic epidermal necrolysis or these skin lesions are typical of toxic epidermal necrolysis, always shift or mobilize the patient to ICU. Okay. And IVIG is the first line of treatment. It has shown to be effective and is now used widespread because it is considered as a dermatological emergency. Identifying it and immediate treatment with IVIG can save lives. Okay, otherwise people can go into dehydration, sepsis, and even death. What are the other treatment options that are available if IVIG is not there? You can use plasma exchange or immunosuppressive drugs like cyclosporin or cyclophosphamide. Okay. So coming on to the prognosis, so the risk of death in patients with toxic epidermal necrolysis can be accurately predicted by toxic epidermal necrolysis specific severity of illness score, which is known as SCORTIN. Okay, so each of the following independent prognostic factors that are listed below a score of 1 is given. So based on the score that is derived after considering all these factors, you decide on mortality risk whether that is involved with the patient. Okay, so if the patient's age is more than 40 years, then you give a score of 1. So each point has a score of 1. Heart rate of more than 120. If there is a history of cancer or any other hematological malignancy, or if body surface area involvement is more than 10%, urea level of more than 10, bicarbonate level less than 20, serum glucose level less than more than 14 millimoles, again is given a score of 1. So based on that, you decide, like if the score is between 0 to 1, then the mortality is only 3.2%. The score is of 2, then the mortality is 12.1%. The score is 3, then you give a mortality rate of 35. And if the score is more than 5, then it is like sure that there is 90% mortality. These people are terminal. And whatever you do, the bringing back the patients to life is extremely difficult, very, very difficult. You will have to explain the risk to the family and then go about it. All right. So that is why it's very important to identify this condition earlier and start treatment as well earlier. So first line of treatment will be IVIG. Remember this in your clinical practice as well. Moving on to erythema nodosum. Erythema nodosum is nothing but inflammation of the subcutaneous fat. Alright, so it is also a form of paniculitis. Histologically, these lesions show vasculitis of small venules and also inflammation of the fat, which is seen as paniculitis. So how do these lesions present? They may usually present as tender red erythematous nodules. Okay, most commonly seen over the lower limbs or the upper limbs, over the shin, and they can occur elsewhere as well. Usually these lesions are resolved within 6 weeks, and usually there is no scarring associated with these lesions. So what are the causes for erythema nodosum? Most common is infection. It can be streptococcal, it can be tubercular, or it can be brucellosis. But most common organism which can cause erythema nodosum is streptococcus. Other systemic conditions that are associated with erythema nodosum are sarcoidosis and IBD. Okay, Behçet's disease, SLE, and other malignancy and lymphoma can also lead to erythema nodosum. Okay, and when it comes to infection, you will have to remember that the most common organism is streptococcus, and rheumatological diseases that can cause erythema nodosum is nothing but sarcoidosis. So always remember, whenever you have a patient with erythema nodosum, always rule out sarcoidosis. Do a chest X-ray to confirm that this patient does not have sarcoidosis. Okay, whenever you see that, the first thing that has to come to your mind is sarcoidosis. Pregnancy is also another common cause. There are certain drugs that can lead to erythema nodosum as well. They are OCPs, sulfonamides, penicillins, antipyretics, montelukast. Even after hepatitis B vaccination, there are some cases that have reported to have erythema nodosum. Okay, and another proton pump inhibitor which is commonly used, omeprazole, is also known to cause erythema nodosum. So these are image examples of erythema nodosum. So you can see the red nodular lesions that are seen over the forearm and the shin. Okay, these are the most common regions that are affected by it, and they appear as nodular swellings which are tender. Next topic is erythroderma. So erythroderma is used when the skin involvement is more than 95%. It can be any kind of rash, but if the total body surface area involvement is more than 95%, then you term it as erythroderma. So the mechanism behind erythroderma is most likely from cutaneous thermal dysregulation. So increased blood supply to the skin leads to heat and fluid loss. And this leads to increased rate of skin cell turnover and sloughing of the skin. So there is detachment of the epidermis and sloughing occurs. Alright, so causes can be any skin lesion where it progresses into erythroderma. So for example, eczema, psoriasis, lymphomas, leukemias. Drugs like gold can also lead to erythroderma. And very rare condition like pityriasis rubra pilaris is also associated with erythroderma. Okay, so this condition is associated with again systemic symptoms because of the widespread skin involvement. They can present with fever, chills, generalized weakness, shivering, etc. All right. So erythrodermic psoriasis can also, like psoriasis can lead to erythroderma. So erythrodermic psoriasis may result from progression of chronic disease to an exfoliated phase. So when psoriasis progresses, where the disease leads to an exfoliated phase, where the plaques covering most of the body become turn into slough. All right. So it is associated with mild systemic symptoms. And more serious form is an acute deterioration. This may be triggered by variety of factors like withdrawal of systemic steroids also. So if the patient is on long-term steroid and suddenly if you're stopping steroid and the patient comes with a widespread rash, you will have to think that this might be erythroderma because of sudden withdrawal of steroids. All right, so always keep in mind whenever the patient is on high dose of steroids, not just because of other symptoms that can be like, for example, steroid insufficiency or cortisol insufficiency, it can also lead to erythroderma. So patient has to be, the steroid dose has to be tapered and stopped. Also, in erythroderma, the patient will need hospital admission. Okay, so this is how erythroderma looks. The first image is like a milder version where, generalized involvement of the entire body where there is erythroderma seen. And it is also known as red man syndrome. And in the next image, you can see that how the disease has progressed, leading to sloughing of the skin. Okay, another important topic from exam point of view is onychomycosis, which is nothing but fungal nail infections. Okay, so these are usually caused by dermatophytes. The most common fungus that is involved is Trichophyton rubrum. It accounts for more than 90% of the case. Okay, also yeast such as Candida and non-dermatophytic molds also can cause onychomycosis, but most common is Trichophyton rubrum. What are the features of onychomycosis? Thickened, rough, opaque nail. Okay, so as you can see in the image, the nails look very nasty. Okay, rough, thick, and you can even see pitting of the nails. Okay, so how do you investigate these patients? You will have to take nail clippings, scrapings of the affected nail, Woods lamp examination can be done. Also, yellow to yellow green fluorescence is a characteristic of fine scales taken from active fungal lesions. So most of these nail infections will have active fungal lesions. All right. So you can take the yellow to yellow green fluorescence, which is taken as positive for the onychomycosis. So the sensitivity of this procedure is reduced when the patients have taken a recent shower. So after a shower, it might not be positive. So the lesions, the nail has to be dry, and lesions have to be dry for this to be positive. All right. So if this is not possible, if this is not a gold standard test, this is just a finding that can be seen in onychomycosis. Gold standard will be now KOH mount from nail clippings and scraping of the affected nails, as well as fungal culture. So how do you treat these patients? So this is a reversible and treatable condition in more than 50 to 80% of the patients. Diagnosis should be confirmed by microbiology before starting treatment. First line of treatment will be oral terbinafine. An alternate could be oral itraconazole. All right. So treatment duration varies depending on whether the fingernails are involved, like the upper limbs or the lower limbs are involved. So if it's a fingernail infection, it has to be from 6 weeks to 3 months. If it's a toenail infection, then the duration of treatment will be from 3 to 6 months. So remember that the duration of treatment varies depending on which part of the nail is involved. Candida infections are usually mild diseases and they are usually treated with topical antifungals, for example, amarolfin. All right, and severe infections are usually treated with itraconazole, which require almost 12 weeks of treatment. Most common organism, as I said, is Trichophyton rubrum. All right, Candida and all the mild variants of onychomycosis. Next is again one more very important topic from exam point of view. It's nothing, it's a very simple topic. It's just so much. Whatever I've put, that is all that you will have to remember for the exam. And this image also you will have to remember. What are Buell's lines? They're nothing but benign. It's a benign nail condition that presents jagged transverse grooves on the nail plane. Okay, it corresponds to an episode of nail growth arrest, which can occur during an episode of severe medical illness. So, for example, the patient has had some very severe critical illness, then there are chances that the patient might develop Buell's lines. All right. So this is nothing. It's self-limiting that this does not require any specific treatment. It's just that you will have to remember that if the patient is having any transverse grooves post a critical illness, it is Buell's lines and it is self-limiting. All right. So next condition is granuloma annulare. So granuloma annulare is a benign inflammatory condition of unknown etiology. It is characterized by dermal papules which can coalesce to form annular plaques. All right, so you can see the image that I put here and the knee. So papular lesions that are often slightly hyperpigmented and depressed centrally. So you can see in the image how the lesion looks. Right, so whenever you see such an image where there is hyperpigmentation with slight depression in the center, you will have to think of granuloma annulare. So mostly affects the dorsum of the hands and the feet and also the extensor aspect of the arms and the legs. And histology reveals foci of degenerative collagen surrounded by areas of granulomatous inflammation. Sorry. And a number of associations have been proposed to this condition, such as diabetes, which is the most common cause of granuloma. So, if you see a patient with this, you will have to think that the patient might have diabetes, and you should also think of whether it is under control or not. So, how do you treat that patient? Mostly, it is self-limiting, and it is only by observation and symptomatic treatment. The and locally delivered steroid in the form of topical ointments can also be used to treat the condition. Next, most important thing is herpes simplex virus infection. So there are two strains of the virus, HSV1 and HSV2. So previously it was thought that HSV1 usually causes oral lesions like cold sores, and HSV2 is responsible for the lesions above the below the abdomen, for example, genital herpes. But of late, it is seen that there can be an overlap between the two. All right. So, what are the main features? Primary infection, you will have to find out where it is. And severe gingival stomatitis, cold sores, that is oral lesion, and genital ulcerations are seen. How do you manage? Oral acyclovir is the first line. Okay, when it comes to gingival stomatitis, and chlorhexidine mouthwash for oral hygiene. And if there are cold sores with mucosal involvement, topical acyclovir ointments can also be used. For genital herpes, also the treatment is oral acyclovir. And some patients with low immunity, for example, if they're on immunosuppressants or if they're diabetic or if they are exposed to patients with herpes, they can have recurrent infections with herpes. So they will have to be taking long-term cyclovir. So, if in a pregnant patient and you find out that the patient is having herpes, elective cesarean section and term is advised if a primary attack of herpes occurs, that is during pregnancy, if it is more than 28 weeks of gestation. Okay. Yeah. So, next is molluscum contagiosum. So, this is also a viral skin infection, common skin infection caused by the molluscum contagiosum virus, a member of the poxviridae family. It is a DNA virus. Okay, so majority of the cases occur in children because of with atopic eczema. So children with atopic eczema are at a higher risk of developing molluscum contagiosum. Maximum incidence is seen in preschool children aged around 14 years. How does it get transmitted? Either by direct contact, close personal contact, or through fomites, contaminated surfaces such as shared towels, doorknobs, pens, and other objects. And it can also spread following scratching to the other sites. So, how do these patients usually present? They typically present characteristic pinkish or pearly white papules, okay, with a central application. And the diameter is usually less than 5 millimeters. So, remember, molluscum contagiosum is it's a papule with characteristic pinkish and pearly white lesions with central application. And lesions appear in clusters in areas where anywhere on the body because they spread because of scratching, and these lesions are extremely itchy. It can spread from nearby sites. And in children, lesions are commonly seen on the trunk and in the flexures. But in age generally, lesions can also occur, which have been found in some patients. In adults, sexual contact may lead to lesions developing around the genitalia, thighs, and lower abdomen as well. Okay. So rare lesions can occur on the oral mucosa and eyelids. And most commonly seen in immunocompromised adults with HIV and with CD4 count of less than 200 cells per millimeter cube. And HIV antibody test has to be performed in any patient with the molluscum contagiosum, any adult patient with molluscum contagiosum. Okay, because it's most commonly seen in immunocompromised people only. Treatment is usually not recommended. It is just symptomatic and observation. Watchful waiting in children for some troublesome lesion. If the patient is having a lot of itching and the lesions are spreading extensively, cryotherapy can be opted. Okay, squeezing or piercing the lesions can be tried, but it is not recommended. This is what they practice, which is not recommended at all because scratching and other kinds of trauma can lead to spread of the infection. Okay, treatment should be limited to a few lesions at one time. Okay, used in older children adults if the healthcare professional is experienced. So because these are very strong immunosuppressants, it cannot be applied throughout the body. Usually, if there is only targeted treatment of specific lesions at first, then the treatment of the other lesions. So, what can be used as topical imiquimod can be used, topical cantharidin, and oral cimetidine can also be used in certain patients with widespread lesions. Treatment may be required if itching is severe, where the patients are having severe pruritus, where a mild topical corticosteroid like hydrocortisone with an emollient or a moisturizer can be used. And if the skin looks infected, a topical antibiotic like fusidic acid can also be recommended. So this is an image of molluscum contagiosum where you can see the slightly raised papule with a central application. Okay. So referral is necessary in certain conditions where the patients are HIV positive, eyelid margin or ocular lesions are involved, and anogenetic lesions are also seen. Next is impetigo. Impetigo is a superficial bacterial skin infection, usually caused by either Staph aureus or Streptococcus pyogenes. Okay, so how do these lesions present? These lesions present as golden crusted skin lesions, typically around the mouth, and they're extremely contagious and they can spread from one person to the other. Okay, management is usually limited and it's a localized disease, usually seen around the oral cavity. Treatment: topical fusidic acid is the first line of treatment. Topical retapamilin is used as a second. Sorry. Any questions? Correct. So topical fusidic acid is used as the first line of the treatment. Topical retapamilin is used as the second line if fusidic acid is not working or is been ineffective. And in case where MRSA is not susceptible to fusidic acid or retapamilin, topical mupirocin can also be used to treat the lesion. Okay. Most common causes: Staph aureus and Streptococcus pyogenes. Okay, so this is how the lesion looks. Extensive, the lesion is very extremely extensive and severe. You can also give oral antibiotics in the form of flucloxacillin and erythromycin if the patient is allergic to penicillin. So the next condition is erysipelas. So erysipelas is a Streptococcus pyogenes infection of the deep dermis and the subcutaneous tissue. Okay, so most commonly caused by the group A Streptococcus. Features: it is usually tender, intensely erythematous, indurated plaque with a sharply demarcated border. Alright, and it has a well-defined margin which can help it differentiate from the other skin conditions like cellulitis. So since cellulitis also infects the subcutaneous tissue, whenever there is a doubt as to whether it's erysipelas or a subcutaneous tissue, you can see that these lesions are well demarcated and they have a very well-defined margin. So how do you treat these patients? Mainly by IV antibiotics, benzyl penicillin or erythromycin. In a penicillin allergic patient, a macrolide is the drug of choice for erysipelas. Okay, there is a 10% chance of cross allergy between cephalosporins and penicillins, but then you can give a test dose and then treat accordingly. So, what are the complications of erysipelas? Sepsis. There can be spread of infection leading to secondary infection in other areas, for example, cerebral abscess, and also venous sinus thrombosis. Okay, so this is how these lesions look. So, for example, see, the lesions are well demarcated, and also if you see the leg here, in a cellulitis, it will be diffusely red with edema. Here you can see there is a well-defined margin. Okay, so this is how you differentiate cellulitis and erysipelas. Next, coming on to leprosy. It is a granulomatous disease primarily affecting the peripheral nerves and the skin. Okay, it is caused by Microbacterium leprae. Features are hypopigmented skin lesions, typically affecting the face, extensors, and buttocks. It can also affect the limbs. Okay, commonly sensory loss is also seen over these hypopigmented patches. So, a degree of cell-mediated immunity involved in a patient decides whether this patient is having a lepromatous leprosy or a tuberculoid leprosy. So, if the degree of cell-mediated immunity is low, then it leads to lepromatous leprosy, where it is multibacillary with extensive skin involvement. Okay, the bacilli count is more. That's why it's called multibacillary. Remember, multibacillary, paucibacillary, and multibacillary, that is also symmetrical nerve involvement. If the cell-mediated immunity of the patient is pretty high, then it leads to tuberculoid leprosy, where the lesions are typically paucibacillary, where less number of bacilli are seen, with limited skin disease and asymmetric nerve involvement. So management is usually with triple therapy. The drugs used are rifampicin, dapsone, and clofazimine. Remember these three drugs in leprosy. Okay. So coming on to Koebner's phenomenon, it is nothing but a skin lesion which appears at the site of injury. So trauma leads to spread of the disease. This is what Koebner's phenomenon means. All right. So what are the lesions which exhibit Koebner's phenomenon? It is psoriasis, vitiligo, warts, lichen planus, lichen sclerosis, and molluscum contagiosum. Okay. So remember, these are just a handful of lesions which exhibit this kind of a phenomenon. So remember, the question might be which lesion does not exhibit Koebner's phenomenon, and they can give you all these lesions. So just remember these like small countries, like whatever is listed here. So next is lichen planus. So lichen planus is a skin disorder of unknown etiology, most probably being immune. So it is thought to be an autoimmune skin condition where the reaction is basically immune mediated. So what are the features of lichen planus? Here, the skin lesions are characterized by itchy papular rash, most commonly seen on the palms, soles, genitalia, and flexor surface. Okay, so the rash is often polygonal in shape with a white lace pattern on the surface. So it is called Wickham striae. Remember, Wickham striae is very, very important. Characteristic of lichen planus is Wickham striae. Okay, it can also exhibit Koebner's phenomenon where new skin lesions appear at the site of trauma. Oral involvement is seen in around 50% of the patient. If there is nail involvement, you can see thinning of the nail plate with longitudinal ridges. Also, fibrin deposits at the basement membrane zone are found in cases of lichen planus, around the where the mucosa is involved. All the immunofluorescence studies are uncommonly done to diagnose it. So this is an example of lichen drug reaction. So what are the drugs that can cause the lichenoid drug reaction? Gold, quinine, and thiazides. How do you manage it? Topical steroids are the first line of treatment. And if there is extensive lichen planus, then the patient might need oral steroids as well as immunosuppression. Okay. Next is lichen sclerosis. Similar to lichen planus, lichen sclerosis is derived from lichen sclerosis epitrophicus. This is an inflammatory condition which usually affects the genitalia and is more common in elderly females. Okay, so lichen sclerosis usually leads to atrophy of the epidermis with white plaques. So there is atrophy and thinning of the skin which leads to atrophy. That is why it leads to sclerosis, and it is called lichen sclerosis. So how do you diagnose this patient? Usually made on clinical grounds, but a biopsy may be performed if atypical features are present. And management is mainly based on topical steroids and emollients. All right. And patients with lichen sclerosis are at an increased risk of vulval cancer. This is also a very important point based from your exam point of view.
Hello.
So remember, lichen sclerosis, there is a high risk of vulval cancer in elderly females. So onycholysis is another nail condition. Here there is separation of the nail plate from the nail bed. So what are the causes of onycholysis? It can be idiopathic. Trauma is one of the main causes because of excessive manicuring or any traumatic injury. Like onychomycosis or any other fungal infections can lead to onycholysis. Skin diseases like psoriasis, eczema, and dermatitis can also cause onycholysis. Impaired peripheral circulation, for example, in cases of Raynaud phenomenon where the arterial supply is not good, this can also lead to onycholysis. And the systemic diseases, for example, hyper and hypothyroidism, and also drugs like tetracycline can cause separation of the nail bed from the nail plate. So next is parvovirus infection. Parvovirus B19 is a DNA virus. It causes disease with various like a huge spectrum, and usually it was identified as a cause of erythema infectiosum. Okay, it is also known as the fifth disease or slapped cheek syndrome, where the slapped cheek rash is seen, which spreads from proximal arms to the extensor surface. Okay, so parvovirus B19, DNA virus, and slapped cheek appearance. This is what you'll have to remember. Well, like most important. Okay. So systemic symptoms can be associated with this disease in the form of generalized weakness, headache, flu-like symptoms, fever, and sometimes it can also be asymptomatic. So most commonly seen in immunosuppressed patients, there can be pancytopenia. can also lead to aplastic crisis. For example, in sickle cell disease, parvovirus B19 suppresses the erythropoiesis for about a week, so which leads to aplastic anemia. Though it is rare, it is commonly seen with parvovirus B19 infection. So, in cases of sickle cell disease and immunosuppressed patient, if there is aplastic anemia, think of viral infection, parvovirus B19. Okay. So, next condition, pityriasis rosea. So it is an acute self-limiting rash which tends to affect young adults, most commonly in people between the age of 10 and 35 years. Okay, so the etiology of this condition is not fully understood, though herpes hominis virus 7 is the major cause of pityriasis rosea is what they have found out. And it does not appear to be contagious. And though there is a theory that it could be HHV7, it is not fully clear. Okay, it is not like proven. So most common features are herald patch. Remember herald patch and filtry appearance for pityriasis rosea. All right. So usually herald patch is seen on the trunk, followed by erythematous oval scaly patch. In a characteristic distribution with the longitudinal diameters of the oval lesion running parallel to the line of the langa. Okay, it can produce a filtry appearance, and it can even be itchy or it can be asymptomatic. Okay. So how do you manage these patients? Usually these lesions are self-limiting and disappear within 4 to 12 weeks. Moisturizers and other emollients can also be used to contain the symptoms. Okay, so nothing in specific for this condition. It's just the symptomatic treatment. Okay, herald patch and filtry appearance is what you will have to keep in your mind regarding this. So this is how it looks. So you can see the herald patch here, which is seen in pityriasis rosea. Next is pityriasis verticolor. It is nothing but it's a fungal infection of the skin. The superficial infection, also known as Taenia versicolor. Okay, the organism involved is Malassezia purpura. It was previously called Pterospora ovale. So common features that are seen here are most commonly affects the trunk. Patches may be hypopigmented, pink or brown in color. That is why it is called versicolor, which is multicolor. So the lesions can be in any color. It can be white, pink, or brown. The scales are usually common in these lesions, and it can also have mild itching. So what are the predisposing factors here? Immunosuppression, malnutrition, and also Cushing syndrome. Okay, so how do you manage these patients? Since it's a fungal infection, you should start with topical antifungals. Okay, and nice guidelines suggest use of ketoconazole shampoo if there is widespread scalp involvement as well. Topical selenium sulfide also can be used by pityriasis versicolor. And if the disease is very extensive and if they are not responding to first line treatment, then oral antifungals in the form of oral itraconazole can also be given. Okay. Moving on to the next condition. So psoriasis, it's a very common condition. It can, a lot of questions can come from this topic in your part 1, part 2, or even PACES exam. Okay. So it's a chronic relapsing inflammatory skin disorder, most commonly characterized by erythematous, sharply demarcated papules and rounded plaques. And these are usually covered by silvery scales. Okay. Usually the prevalence is around 2% throughout the world, and the peak of incidence is, there are 2 peaks of incidence. One is between 16 to 22 years and the other is 57 to 16 years. Okay, males and females are equally affected. What is the pathophysiology of psoriasis? So it can be multifactorial. And there is no clear-cut hypothesis as to this is the cause of psoriasis. So first thing can be genetic. There can be a polygenic inheritance. It is also be shown to associated with HLA B13, B17, and CW6. More common in European population. And also there's a strong concordance that is 70% in identical twins. That is monozygotic twins. Okay. The other can be immunological cause where there can be abnormal T cell activity which stimulates the keratinocyte proliferation. And these are usually mediated by the T helper cells producing interleukin 17. So what is interleukin 17? It is a pro-inflammatory cytokine which is expressed at high levels in psoriatic lesions. So when this is important in the pathogenesis is because, in severe psoriatic lesions which are not which are refractory to the first line and second line of treatment, immunosuppressants in the form of interleukin 17 monoclonal antibody, that is efgartigimab, can be used to control the lesion. Okay, this is used as a last resort in recurrent and refractory psoriatic lesions. So next can be environmental causes, like it can be worsened by trauma, stress, or even it can be worsened by sunlight exposure and infrared UV radiations as well. Okay, so what happens here is that because of increased microclotting activity of the cells in the Malpighian layer of the epidermis. Okay, so it is like this is usually in both the stratum basalis and stratum spinosus layer. So there is increased mitotic activity, increased proliferation, increased production of keratinocytes, and leading to plaque lesions. So there are different subtypes of psoriasis that have been recognized. So plaque psoriasis is the most commonest type, resulting in typical well-demarcated lesions. These lesions are usually red, scaly, and usually seen over the extensor surfaces, over the external surfaces, sacrum, and the scalp. Next is flexure psoriasis. So this is usually not a scaly lesion. These are usually smooth lesions. Okay, these are all variants of psoriasis that you can see. Next is guttate psoriasis. So here transient psoriatic rash, which is frequently triggered by a streptococcal infection, is seen. Okay, these rashes are teardrops and lesions and red, and it can appear anywhere on the body. Next is pustular psoriasis. This is you commonly seen over the palms and sole. Okay. Features that are common to psoriasis is they are red salmon colored patches, which are plaques with silvery scales. It can occur in hidden sites as well, for example, scalp. So whenever you have a patient with psoriasis, never forget to examine the scalp, behind the ear, the elbows and knees, and also the ankle. Okay. So these are common sites. Even when the patient shows you that they have rashes over their face or neck or forearm, you will have to examine these lesions for hidden lesions. Alright. So the scalp is often involved in psoriasis. Most commonly, it causes telogen effluent. That is, the hair follicles are forced into a telogen resting state. As we've discussed earlier, this is a temporary stage where the lesion can be resolved with the control of the psoriasis. Okay. So what are the other features that you can see in psoriasis? Nail involvement can be there, leading to pitting of the nails and onycholysis. They can also have joint involvement, leading to psoriatic arthritis. New lesions usually appear at the site of injury. Here they also show Kovner's phenomenon. And Auspitz sign is also very, very important. It is nothing but small bleeding spots that are seen when psoriasis cells are scraped off. Okay. And it can also be associated with like eye involvement can also be seen in psoriasis, which is in the form of anterior uveitis. So what are the complications associated with psoriasis? Psoriatic arthropathy is common, and there can also be joint involvement like distal interphalangeal joints, where nail pitting and severe arthritis in like advanced severe conditions. You can also see arthritis mutilates, where the joints are destroyed. Okay. And there is increased incidence of metabolic syndrome, cardiovascular disorders, and increased incidence of venous thromboembolism. Okay. There can also be psychological distress, like because of the lesions, there can also be emotional disturbance in these patients. So how is it usually diagnosed? These psoriatic lesions are typically like typical lesions, and they're usually diagnosed clinically. Okay, skin biopsy is very rare, and when you do a biopsy, how do you confirm it? You can see hyperkeratosis, parakeratosis, and Monroe's microabscess. This is nothing but neutrophils in the stratum corneum region of the epidermis. So other important factor is what are the things that can exacerbate psoriasis? Okay, trauma, alcohol, and drugs. So drugs, you will have to remember all drugs, because whenever you get a history as to this patient is on this medication and the rash has been exacerbated, the main treatment will be to stop the offending drug. All right, so the drugs are beta blockers, lithium, anti-malarial, gold salts, NSAIDs, AC inhibitors, infliximab, Antibiotics like tetracyclines and penicillins, and sudden withdrawal of steroids can also exacerbate psoriatic lesions. So management first line will be topical steroids plus a vitamin D analog for chronic plaque psoriasis. Okay. So how do you manage? Usually you give emollients to reduce the scale production and also reduce the pruritus. Pruritus and itching can lead to scratching, which also can lead to secondary injury. Okay, so emollients are very important. First line will be potent corticosteroid, which is applied once daily, plus a vitamin D analog. Okay, which has to be applied again separately for up to 4 weeks. So you see if the lesions are resolving, then 4 weeks. If it is not, then you go for second line. Okay, after 8 weeks of therapy with first line agents, if it is not resolving, then you give a vitamin D analog twice a day. Then if it is not resolving with 8 to 12 weeks of second line therapy as well, then you go for the third line. Here you give a potent corticosteroid, which is applied twice daily for up to 4 weeks, or also a cold tap preparation, which is applied once or twice daily. Okay, short-acting diethanol can also be used for treatment. So remember first line, second line, and third line. Potent corticosteroid with vitamin D analog. Second line would be vitamin D analog applied twice. Next would be potent corticosteroid with cold tap preparation. Okay. So using topical steroids in psoriasis, recommends at least 4 weeks, like minimum 4 weeks break between starting another course of topical steroids in psoriatic patients. Because here we give highly potent steroids that can be high rates of systemic absorption and can lead to other side effects as well. They also recommend using potent steroids for no longer than 8 weeks at a time, and very potent corticosteroids for less than 4 weeks at a time. Like continuously, you cannot use for more than 8 weeks in case of potent, and more than 4 weeks for very potent steroids. And moving on to vitamin D analogs, examples of vitamin D analogs are calcipotriol, calcitriol, and tacalcitol. Okay. These work by reducing the cell division and differentiation. Usually, adverse effects are very rare. These vitamin D analogs also reduce scale production and the thickness of the plaque, but the eczema might persist. So, and also they're contraindicated in pregnancy. Maximum dose that can be used is 100 mg weekly for an adult patient. Okay, so these are psoriatic rash. Here you can see how the rash was before, extremely scaly and erythematic. After vitamin D analog therapy, you can see that the scales have disappeared, but the erythema is still persisting. Okay, for scalp psoriasis also, the first line treatment is potent corticosteroid. And if there is no improvement like in others also, after 4 weeks, you move on to second line treatment. So secondary whatever we saw was primary management. Secondary management includes phototherapy and systemic therapy. Phototherapy includes narrow band ultraviolet B rays. If possible, this should be given at least 3 times a week. And then photochemotherapy can also be used in coma, soralin plus ultraviolet A light. Okay, so PUVA is also very commonly used. And the adverse effect that can be seen here are skin aging and high risk of squamous cell carcinoma. Okay, systemic therapy is when the primary and systemic secondary therapy is failing, and the topical treatment is not effective. Okay, so here are indications. Other indications are extensive psoriasis where there is more than 10% body surface area involvement. Localized psoriasis where there is functional involvement in the form of impairment in the form of joint involvement and destruction of joints, severe pain because of psoriatic arthritis, and also when phototherapy has not been effective and there is relapse of the condition. Drugs commonly used are methotrexate, cyclosporin, and biological agents like infliximab, etanercept, and adalimumab can also be used. Okay. Before using any biological agent, it is important to check if the patient is immunosuppressive and is having any other kinds of infection. For example, it is important to screen for tuberculosis and viral hepatitis. Okay. And among the biological agents, etanercept and infliximab are commonly used. So TNF alpha, anti-TNF alpha agent, etanercept is the most appropriate first line agent. Okay, there are newer agents like brodalumab and ustekinumab. They are anti-IL-17 monoclonal antibody and interleukin 12 and 23 blocker. Okay, so what is the advantage with ustekinumab is that it does not reactivate TB because it is not a anti-TNF agent. So remember that it does not which drug does not reactivate TB, which biological agent does not reactivate TB. It is ustekinumab. Okay, next is guttate psoriasis. I discussed this earlier as well as a subtype of psoriasis. This is nothing but a here you see teardrop papules mainly because of streptococcal infection, which was there previously 2 to 4 weeks prior to the lesions. Okay, so this is how gutted psoriasis looks. You can see the teardrop lesions here. So management is usually self-limiting and the lesions resolve spontaneously. So if the lesions are widespread, that is if there is more than 10% body surface area involvement, then phototherapy with Sorel and ultraviolet B can be used. And in cases of recurrent episodes, it will be mainly because of recurrent streptococcal infection. So tonsillectomy might be needed for that patient. So this is just a table differentiating gutted psoriasis and pityriasis rosea. Here, so the treatment and the so in gutted psoriasis you see teardrop lesions. In pityriasis rosea you see herald patch and classical fir tree appearance. Okay. Treatment pityriasis rosea is usually self-limiting. Here also gutted psoriasis is self-limiting. If not, you give topical agents and UVB phototherapy. Okay. So here you can see the gutted psoriatic lesion with also tonsillitis because streptococcal infection. They can give you an image like this and then ask you for treatment or ask you what condition it is or what type of psoriasis it is in the exam. All right. So I think that is all for today's class. We will just discuss few MCQs which I have drafted from today's class. They're very simple MCQs. You can take your time. I'll just give you 5 to 6 seconds to go through the question and then we can discuss the answer after that. So a patient present with spoon-shaped nails, that is koilonockia, which is the common underlying condition that you have to screen the patient for. A, COPD, B, iron deficiency anemia, C, hypothyroidism, D, hypoalbuminemia, and E is arsenic poisoning.
Iron deficiency anemia.
Yeah, the answer is iron deficiency anemia. Okay, so here there you can see spooning of nails, and most common is iron deficiency anemia. Okay, next is a patient presents with white crumbly debris under the free edge of the nail. Okay, and a thickened nail plate. You suspect distal subungual onychomycosis. So, what is the gold standard investigation for this patient? A, Woods lamp examination. B is skin prick test. C, KOH mount and fungal culture. D is full blood count. And E is biopsy of the nail matrix.
KOH microscopy and fungal culture.
Yeah, right. So you will have to do a KOH microscopy and a fungal culture. You will take nail clippings and nail scrapings to do this. Okay. So this is the gold standard investigation. And before starting oral antifungals, you will have to confirm that the patient is having onychomycosis and you will have to start the treatment after that. So next question. A 45-year-old woman presents with thickened yellow-brown brittle toenails. Okay. Skin scraping and nail clippings are sent for microscopy and culture. So what is the first line the treatment for trichophyton rubrum? Oral fluconazole, oral terbinafine, topical hydrocortisone, oral griseofulfin, or topical clotrimazole?
Oral terbinafine. B.
Sorry?
Oral terbinafine.
Yes, option B. Oral terbinafine is the answer. Okay. And trichophyton rubrum, remember that is the most common cause of fungal nail infections. Next question. Upon examining a patient who recently recovered from a severe bout of sepsis 6 weeks ago, you notice horizontal grooves across the nails. So what is the correct term for this finding? Meukes lines, Mies lines, Bewes lines, koilonockia, or splinter hemorrhages?
Bewes lines. Bewes.
Yeah. As we discussed, I showed you the image as well. These are nothing but horizontal grooves that are seen for critical or chronic illness. Okay, these lesions are self-limiting and do not require any specific treatment. Next question. A patient with known celiac disease presents with intensely itchy vesicles on their elbows and knees. What is the first line medical treatment for this condition? This I have not discussed yet. I think I will discuss in the further classes. But anyway, we can just go through it once. Option A, topical steroids. Option B is oral dapsone. Option C is oral fluconazole. Option G will be oral methotrexate. And last will be IVIG. So this
oral dapsone dermatitis herpetiformis.
Correct. Yes. So celiac disease, the most common skin lesion associated is dermatitis herpetiformis. And the first line of treatment is dapsone. Okay. Yeah. Next is erythema nodosum is associated with all of the following except. So which conditions are commonly associated with erythema nodosum? Sarcoidosis, IBD, streptococcal infections, primary biliary cholangitis, pregnancy.
PBC, primary biliary cholangitis. It is
Simplex, herpes zoster, corticosteroid, all of the above.
all of the
No, it is most commonly seen in it can be seen in all conditions, but most commonly seen in herpes simplex. Okay, so the primary lesion of molluscum contagiosum is option A, macule, papule, plaque, vesicle, and pustule.
basical.
Sorry?
Basical D.
No, molluscum contagiosum is a papule. Okay, so it is an
Papule.
umbilicated papule. So you will see reddish papules with central umbilication. Okay. All right. So thank you so much. I've tried to cover most of the topics today as well. And there are a lot more topics to discuss. I think we will discuss that in the next coming classes. Okay.